So next we have Elone Yehualashet. She's with the UPMC group, and she's presenting to us Glp-1 receptor agonists associated with improved survival after infrainguinal bypass in diabetic patients.
Good morning. My name is Elone Yehualashet, and I'm a rising fourth-year medical student. Thank you for the opportunity to present our work. We have no disclosures. Glp-1 agonists were initially indicated for the treatment of type 2 diabetes, with exenatide being the first FDA-approved drug in 2005, shortly followed by liraglutide in 2010. In 2015, following the outcomes of two major clinical trials examining the role of GLP-1 agonists in promoting weight loss and improving glycemic control, these medications became approved for weight loss even in patients without diabetes. More recently, several major cardiovascular outcome trials have established the efficacy of these drugs in reducing cardiovascular risk and related mortality. PAD, a cardiovascular disease equivalent, has not yet been studied in these cardiovascular trials, despite cardiovascular disease being the leading cause of death in these patients. Furthermore, limb events have not been an outcome of interest in these trials. Interestingly, there's one recent randomized control trial out of Italy of 55 patients who either received liraglutide or placebo. This trial found that use of liraglutide was significantly associated with improved limb-related parameters, including improved walking distance among claudicants and improvement in lower extremity perfusion. But overall, currently there's not much that we know about the effect of these medications in people with PAD. Thus, the objective of this present study is to evaluate the effect of GLP-1 agonists in patients with PAD following lower extremity bypass, and these patients are also diabetic. This was a retrospective review conducted at a multi-hospital healthcare system between January 2019 and December 2024. Patients over the age of 18 with a known diagnosis of diabetes and PAD undergoing infrainguinal bypass were included. The primary outcome of interest was survival. Secondary outcomes looked at MALE and MACE, and we additionally looked at metabolic parameters, including BMI, A1C, and lipid labs. Kaplan-Meier analysis evaluated time to event and survival outcomes, and Cox regression was used to assess the impact of predictor variables on the outcomes, adjusting for significant covariates. In total, 389 patients undergoing 410 bypasses were included in this cohort. 40 patients, or roughly 10% of the entire cohort, was on a GLP-1 at time of bypass. Over the study period, we saw a significant rise in the use of GLP-1 agonists from 7% in 2019 to 17% in 2024. Overall, our cohort was predominantly male, white, and either overweight or obese. Baseline characteristics between groups were similar. However, patients on a GLP-1 agonist were significantly younger with a higher BMI and were more likely to be overweight or obese. Concerning comorbid conditions, patients not on a GLP-1 agonist were more likely to have end-stage renal disease, and notably, GLP-1 agonists are contraindicated in patients with end-stage renal disease. The most commonly cited indication for intervention was chronic limb-threatening ischemia, followed by acute ischemia. Patients on a GLP-1 frequently had a bypass involving the tibial vessels, but this difference was not significant. Analysis of in-hospital events revealed comparable outcomes between the groups. Notably, increased respiratory risk among patients on a GLP-1 agonist was not seen in our cohort. This was of interest because risk of perioperative complications with the use of GLP-1 agonists is commonly cited in the literature as a potential concern due to the delayed gastric emptying effects of these medications, thus possibly increasing the risk of aspiration. And though we did not observe any respiratory events, we weren't always able to guarantee that these patients had a true drug holiday or that the drug was held at time of surgery. Looking at the long-term follow-up for patients who survived the initial hospitalization, 392 patients were available for follow-up with a mean follow-up duration of roughly 24 months. Rates of complications, including infection, bypass revision, and amputation, were similar between the groups. Metabolic parameters revealed on long-term follow-up an improvement in parameters across the board among patients on a GLP-1 agonist with a significant reduction in cholesterol levels. Analysis of our primary outcome revealed that patients on a GLP-1 agonist had significantly greater overall survival at 2 years, with almost 95% of this cohort surviving at 2 years, as compared to 71% of patients not on a GLP-1. We additionally carried out this analysis to 5 years and saw sustained significant survival benefit among patients on a GLP-1 at 5 years, though the number of patients at risk in each group was low. On adjusted analysis of 2-year survival, controlling for BMI, sex, history of smoking, and underlying conditions, including end-stage renal disease, GLP-1 agonist use was significantly associated with reduced risk of mortality at 2 years. Additionally, patients on a GLP-1 had significantly greater freedom from a major adverse cardiovascular event, which we defined as a non-fatal or fatal MI or stroke, with 100% of this group experiencing freedom from MACE at 2 years versus 86% of patients not on a GLP-1. Analysis of freedom from MALE, which we defined as a major amputation or major reintervention at 2 years, revealed that GLP-1 agonist use was not significantly associated with greater freedom from MALE, with 57% of patients in this group experiencing freedom from MALE versus 56% of patients not on a GLP-1. This was a retrospective review, and due to the novelty of these medications, our sample size was limited, thus possibly limiting the power of our study. In conclusion, patients in both groups had similar baseline characteristics with the exception of end-stage renal disease. However, patients on a GLP-1 agonist had significantly improved outcomes. GLP-1 agonist use appears to confer survival benefit at 2 years with greater freedom from MACE at 2 years and result in improvement in metabolic labs. Our results did not show a difference in male, but we were limited by small sample size, and this outcome should be explored further in a larger cohort. Overall, our results are very promising, and future studies are warranted to further establish the efficacy of GLP-1 agonists and improving outcomes in PAD patients with and ultimately without diabetes. Thank you. Happy to take any questions.
Great presentation. I might have missed this, but did you control for dialysis or end-stage renal disease in those patients for mortality? Because you often wonder, like the dialysis patients that have CLTI, those are the ones that die. And so that was controlled. I must have missed that slide.
Yes. I don't know if I can go back. Sorry. Okay, great question. So on adjusted analysis, we did control for dialysis, and even then, GLP-1 agonist use significantly was associated with reduced mortality in those patients. So, thank you.
Cassius Shar in New Haven, thank you, very nice talk. Did you look at also control of diabetes, like by hemoglobin A1C or insulin use? And do you think that could have confounded your results? And my other question is, do you think those patients really are, surviving longer, or do you think the use of GLP-1 may be also a surrogate of better access to care, as these are expensive medication and a lot of patients cannot get those medications because of insurance limitations?
Okay, thank you for your question. So the first question, sorry, do you mind repeating the first question with the diabetic
Hemoglobin
patients?
A1C, control of diabetes in general in those patients.
Yeah, so the A1C was not significantly different between groups, so we didn't control for it on adjusted analysis because there was no significant difference. All these patients were on a medication, so essentially I would say their diabetes was pretty well controlled if they were on a non-insulin medication. And then the second question about are they surviving longer because of the effect of these medications or because of improved access to care. We looked at two things. We looked at one, the healthy user effect, which could be if someone is taking antiplatelet, if they're taking aspirin and such, that could also be someone that's probably has better access to care. And additionally, ultimately there was no difference between groups. So I would say that they pretty much have pretty good access to care. These medications are expensive, and so I think that concern would probably be more of a concern among patients that don't have diabetes, because then they would be taking it for weight loss. And so these patients, so the medications are expensive. I don't think we have to be too concerned about that, but if we look at PAD patients without diabetes, those are patients that can probably afford this for weight loss, and I don't think that outcome, we might need to consider that in that case.
Excellent presentation.
Yeah,
thank you.
Thank you.
Hey, Matt Goldman from Wake Forest. Thank you very much for presenting this. I think we're all pretty good at studying limb outcomes. Where we still are really bad is at keeping these people alive at 5 years. Obviously, we know with the new guidelines for PAD that these should be implemented into medical regimens for patients with PAD, so we can try to figure out how to make them live longer. Whose job is it to prescribe this? Is this ours as vascular surgeons? I've personally have never prescribed a GLP-1 agonist, but most of my patients are not on one. even though guidelines recommend they should be. Would you recommend that it would be our jobs as vascular surgeons to be implementing this medication, or is this something that we need to communicate better with primary care or preventative cardiology? Thank you very much. I think focusing on mortality in these patients is great because we haven't cracked that nut, obviously. So thank you.
Yeah. Thank you for your question. So in these cardiovascular outcome trials, they were looking at like the cardiovascular benefit and that these patients survive longer. So really, it's like the cardiologists that are really interested in this and the primary care doctors. But I think like considering that the leading cause of death in these patients, being cardiovascular disease, if we can ultimately, and what we're going to do is we're going to continue following these patients, if we can ultimately prove that our findings truly understate like that these patients on a GLP-1 agonist have improved survival at 5 years, I think then it becomes our responsibility, I'm not yet a vascular surgeon, but as a vascular surgery community, to ensure that these patients have equitable outcomes, these PAD patients do, and if that means prescribing these medications to these very vulnerable patient population, then it does become like our responsibility ultimately, or as a community.
I believe I heard fourth-year medical student.
Yeah.
Okay.
Great
So
job.
I haven't met you yet, but I'm very proud. I would say, you know, when I think about the patients that I take care of, both at my university practice as well as my VA, you know, many of them don't know the difference between an antiplatelet or an anticoagulation medication, or if they're on one or not. And if I say statin, they're like, huh? So, but they all know Ozempic, whether they're on it or they want to be on it or whatever, right? So I think it's really important that we better understand this particular class of medications and the outcomes on the patients that we treat and the procedures that we do. And I think it's just, you know, wonderful that you're presenting this data and have such a command of the data too.
Thank you.
Nice job.
Thank you, everyone.